before we talk about your journey, I kind of want to talk about detox protocols, because that's something that you've been working on. Because what we're realizing is that there's most likely shedding, there's people vaccine injured, and a lot of people were duped into this, and they're looking for options on how to detox. And then you have a lot of people that weren't duped into this, that are hanging out with people that were duped into this, that have shedding. So it seems to be a big concern. Tell us a little bit about how the detox protocols work.
Thank you. Yeah, well, just to clarify real quick, I'm a physician assistant. I never want to take a title that is not truly mine, so I'm not a physician. But you're correct. We were just talking about that a little bit back before we came online here, that everybody has a unique interaction with this new technology, which we call modified RNA. Whether it's through shedding, which we do believe is a real thing. If you listen to some of the lectures from Frontline Critical Care Alliance physicians, they've been doing some, clinical assessments of that, where, for example, I'll have a husband-wife team come in. The husband got vaccinated, the wife did not, but the wife is having some issues. She might be having a rash, or she might be having, hyperinflation of her allergy symptoms, spurred on by mast cells. So there is some premise of thought that people can be affected by this transference of theoretically genetic information. So we would treat somebody like that with preventative and prophylactic strategies. Some call it a detox, but I would call that a little bit more preventative. And we use things like the nattokinase, curcumin, and bromelain that Dr. Peter McCullough talks about to really help eat away at any spike protein, amyloid-like proteins, and fibrin, which are the byproducts of that modified RNA instructions. And we might use something like ivermectin in a lady, or hydroxychloroquine of that nature. But then we have people who have actually taken the shots. We have research that shows that the modified RNA now stays in our blood system up to 6 months. S1 subunit of the spike protein can stay in our white blood cells, maybe up to 15 months. What research has shown us, lymph nodes, 2 months. So we know that there's definitely evidence that this modified RNA technology does not go away in 2-week time frame like it was supposed to. So how do we detox that? The science is not perfect yet, but the strategies are there. So we use repurposed pharmacological drugs, like I had mentioned, hydroxychloroquine, ivermectin. We use, again, the nattokinase, curcumin, and bromelain to target any byproducts from these shots. What we've also been doing over here is we've been using some peptide therapies to kind of help with any symptoms that have manifested from the continued persistence of that genetic information in your body. For example, we use oxytocin, which is a peptide. It's a spray that we can do up your nose or give it to you sublingually. It can really help people that have ringing in the ears, tinnitus. It can help people who have had anxiety from just taking the shot. It's very good for social bonding. It's very good for insomnia. So we're using some unique things to target symptoms. And then we also use some repurposed drugs that have far more proven clinical efficacy and safety profiles for over the years, like low-dose naltrexone, to help mitigate effects that we know can now be common from these modified RNA shots, 6 months, 1 year, 2 years, 3 years out from actually taking the injection itself.
Wow. So tell me a little bit about how did you guys arrive, or the people you work with these detox protocols? Why should the viewer trust these detox protocols? I mean, they've heard, obviously people are quite cynical now. They've heard all sorts of things. What is it about these detox protocols that makes them so special?
Well, a few things. One, a lot of the research that's gone into this, if I'm talking about things like the nattokinase, the curcumin, the bromelain, it came from Dr. Peter McCullough, and it came from Frontline Critical Care Alliance physicians. These physicians are some of the most published physicians in the literature and research world in the U.S. They are physicians who have developed protocols before that have been trusted, tried, and true. And they were the voices that were correct in the treatment of acute COVID. So when I'm asking myself, let's just say as an American public citizen, who am I going to trust to lead and guide me down the road of health, into wisdom, and into integrative and innovative solutions? I'm going to look at the body of work that stands behind these individuals, and those individuals with FLCCC and Dr. Peter McCullough, et cetera, the wellness company, for example. They are the ones that really can be certified, and who I, as a clinician, do believe in and do value their pedigree and their mantras and their protocols that they have since developed. So, I'm not in the research seat of the lab. I'm not taking blood out and plating it on a slide. But I'm someone who's a steward of information, and I'm doing a lot of continual research and trying to harvest the latest data from different clinicians of whom I believe and trust. There's some work out by a Dr. Anna. I'm going to kind of butcher her name. It's MIC, I believe, HELA. I have to double check on that. She's in Washington, but she's been doing a lot of research on how to degrade these, like hydrogel type clots that we see in some people post-shot or even post-infection. And so I follow work from different providers in different respective spheres who have unique approaches, but that have been vetted and backed by their integrity and then the quality of their work over years. And so we start there. And then second, we look at the medications that we're using or repurposed pharmacological drugs like low-dose naltrexone, ivermectin, hydroxychloroquine. We have a lot of data on these drugs, and we've used them for a lot of different purposes over 50 plus years. I mean, ivermectin itself, we all know this, but or maybe some of us don't, but it won the Nobel Prize for its efficacy in curing river blindness and its safety behind it. I mean, ivermectin in some ways is safer than Tylenol. So I hang my hat on things like that have been trusted, true, and proven over the years of time. Not something like Paxlovid, which just came out and was repurposed and is the sexy new drug on the block that was actually antiviral created for HIV. So to answer your question in a little bit of a roundabout way, that's how I make my algorithms, decide on courses of treatments, and place my trust back into things that honestly, the fabric of medicine is built on trust, and that's been a little shaky over these last 3 years because of what's happened with COVID. So,
I mean, what you're saying, sounds very logical. There's a couple of questions come to mind. Is there a lot of people ask me that have been vaxxed? Is it possible?
Sure.
And we hear all sorts of things from just feeling weak and tired to memory loss to actual myocarditis and a whole bunch of things. Is it possible for people to get back to normal using these detox protocols?
Yeah,
meaning
it's a good
like
question.
before? Yeah.
Sure. So clinically, yes, I have experienced people get back to their baseline. For example, people saying like I had an individual who could not get up off the couch for more than 15 minutes a day. And within our 90-day program, we had gotten him up to riding a bike 4 to 5 times a week for 40 miles. That's a much better quality of life than being on the couch, right? However, do we have the information of that all clear signal in the genetic space, in the hematological world or in the immune system database as to when does the problem go away, right? Or when does the modified RNA instruction shut off? No, we don't have that signal. We don't have that certainty right now. So clinically, yes, I can help you get better. But do I have the data point that says, okay, red light, green light, shot turns on, shot turns off? I don't. So there's a two-prong, I think, to that answer to that question. Yes, clinically I've helped people get well. I've gotten people's taste and smell back who have not had it for 2 years, which is a huge quality of life thing. I've helped people who've been dizzy persistently for a year or have chronic migraines to the point that they can no longer go to work and are on disability. We've been able to help them have either less frequent migraines, and we've been able to help them not be dizzy anymore at all. But again, do I have that all clear signal in the background? Not yet. So I have to tailor their therapies kind of to clinically guess what's the least effective or the minimum effective dose of things and frequency of things that I can give to you to maintain a quality of life until I get that all clear signal from research land or, the powers that be that can speak to this more adequately than I.
Let me ask you, like what you're saying was very logical in terms of these detox protocols. You're saying, okay, we're going to the most published doctors, we're going to the most experienced doctors about all this stuff. But yet when this whole thing started, it seemed as though those doctors were being muted. I mean, Peter McCullough, I remember meeting him very early on, frankly, in a dark room where there was like 20 people there. It felt like literally the underground operation against Nazi Germany in 1942. That's what it felt like. We're like hiding out and we're scared, Now he's become internationally respected, one of the most respected doctors out there. Like, how did that not happen? The most logical thing not happen 3.5 years ago?
That's a good question. I can only speak to my experience being in the hospitalist community. I received my instructions and my orders from the infectious disease team and from the administration. And then being a physician assistant, I am subjected to some degree underneath the leadership of a physician, right? So my initial data came from those respective partners. But then what happened was my ability to observe clinically as I'm doing process, procedure, and protocols um, intersected and skizzed, if that's even a word, created a dichotomy between what I was being told and what I was seeing, and then the things that we were using that weren't working appropriately to treat commonly known problems. And so my red flags went up, and that caused me personally as a clinician to start looking for different answers. And that's how I found people like Dr. McCullough. That's how I found the FLCCC. And others that have stepped into this new frontier of medicine where we in this post-COVID era. Am I answering your question correctly? I'm tracking a little off, I think. But how do we? What was your original question? I just want to make sure I get back to the heart of the point.
Well, how did like all the logic of being going after the best doctors, getting the best researchers versus, I mean, frankly, some like stooge that was paid to lie. That's what it seems like at this point. Why do we go down this road? Why did so many doctors allow it to happen? Professors, I mean, intellectuals. It just seemed like a whole breakdown of the entire community.
Well, there's a premise of trust within the community. We trust that the powers that be, the CDC, the HHS, whatever certifying board of credentialing you're underneath, that they've done their due diligence and they've done their research or their homework and they've certified it all. When you're in the hospital setting, for example, it's myself and a physician in this LTAC setting that I was formerly at, we have 24, 23 beds and it's just the two of us. And half of those are critical care ICU patients with vents or drips, things that you are very time critical and are very detail oriented and honestly critical thinking relying upon. And so if you're seeing that breadth and depth of patients, and then you throw on a pandemic and the onslaught of admissions that's coming in and such that nature, to be frank, we didn't have time to maybe do our own homework as we should have been, though. But at the beginning,
it was almost like a blitzkrieg type sneak attack, kind of, where like, whoa, what's going on? Yeah,
right. What's going on? Who knows what? Where do I? So in that initial phase, my trust is going to go directly to the infectious disease doctor. He did the residency. He's done the research component. He's evaluating the literature. He's attending the conferences or the voice calls. So initially, that's where I'm going to go to. But as things started to roll out, and for example, I would have patients come in who had been given saraluumab and remdesivir, which is an interleukin-6 inhibitor, so it calms down the inflammation from your immune response. And then remdesivir, as we all know, antiviral. It did not do well, neither in COVID or the Ebola trials. But I would see those patients roll in my door and be vented and intubated and need 3 weeks to 3 months of recovery and therapy or expire. And then I would see that, maybe an 85-year-old lady who had heart failure or, kidney disease or diabetes, and the aggregate of her conditions did not allow her to receive the remdesivir or the saraluumab. And she would be on high flow nasal cannula, 40, 50 liters of oxygen, but she'd do fine and she would wean off of it in 3 weeks. And so I started assessing that and saying, hey, either COVID is really big, bad, scary, or we're missing the mark and maybe our drugs are causing some side effects. So just by the powers of observation, I started not disagreeing, but maybe standing back and asking new questions. And then reading the CAT scans of people who were vented, because we oftentimes got a few of those during their course. Even the radiologist started sparking that type of curiosity, because as I was reading it, you could say that's fluid, and you could say that looks like inflammation, or you could say that looks like scar tissue or connective tissue disease disorder or some autoimmune process that's happening, which can be a side effect from some of these drugs. And so the radiologists were documenting that at the same time that I was starting to think it and go through these materials myself. And so that kind of started the peeling back of the curtain and the initial onslaught that I had in curiosity as to, are we on the right track? Because right now I'm just receiving orders and I'm trusting, who's gone before me or who has the pedigree to validate that. But me as a clinician in the seat actually treating this patient right here is seeing some things repetitively that seem to be amiss. And so that's what really kind of started my skew into a different way and a different, not following the masses, I guess I should say, at that time.
Totally. Yeah. So tell us a little bit about your journey through all of this. I mean, obviously,
Yeah.
when this first started, you weren't really aware none of us were really aware that we were all
No.
being lied
Yeah.
to. Other than,
Right.
I mean, few enlightened ones. I don't know. I mean, I think Dr.
Sure.
McCullough, it's like, got a
Yeah.
message from God or something. But we didn't
Yeah.
know what was going on. So tell us
Right.
about that journey.
Yeah, we were in the beginning initially. I was buying the N95 masks from the supplier who drove in from Arkansas down in the parking lot of the hospital field. None of us were ready in that sense. But to your question, part of my evolution began with just the clinical observation. But then, the other part of it was my own personal experience with COVID. I did not realize how ill-equipped the outpatient medicine sector was in treating it and how restricted they were to some degree in being able to be adept with therapies to handle it. And honestly, the primary cares were, calling you up and saying, hey, when your cough is gone, then you can come see me, which that's just so twisted. I got that direct answer myself. And then honestly, my personal experience was that I was restricted from getting the monoclonal antibodies because, direct quote, I was too healthy. And at that time they were rationing them, for people who needed them more than I. But since when do we do that in the world of medicine? We don't restrict treatment from the healthy. So a lot of things in that unique experience that I had as well further opened up that gate for me to see, of course we have a hospital crisis. Nothing's being done in the outpatient sector appropriately to treat this. So that was another big stepping point for me. And I actually wrote to a lot of legislators at that time because my blood pressure was starting to rise. And, I was technically a clinician. I had political connections. I had influence. I had the resources and funding. I had health insurance, everything that I should have to be able to get treated. And yet I could not. And so I ended up having a bad COVID case. And by the grace of God, it only took me 3 months to get over. But still, it opened my eyes. And then I guess the ultimate story would be as these shots rolled out, I started noticing people coming into the hospital with clinical symptoms and syndromes or clusters of things that just didn't make sense, irrespective. They were irrespective to their age, their comorbidities, and then their general presentations. And traditional medical therapies were not working to mitigate the symptoms as we previously knew. And so I had one patient who was mid 80s, and her family's authorized me to tell the story, but she went into acute renal failure and needed hemodialysis, which is the filtration of your blood system when your kidneys fail. And then she went acutely psychotic, so she didn't know her name. She wasn't able to feed herself. She was not able to participate in physical therapy and daily care of living type activities. And, the hospitalist workup before I got her said for a month, we don't know what it is. We looked at every infection under the sun. We looked at every, malignancy type of possibility. We've checked her kidneys out. We don't know why they failed. So she has Alzheimer's disease. She just all of a sudden developed it out of the blue, and it's been really progressive. And, she starved herself, and that's why her kidneys failed. And nothing in that story is natural or progressive. And so when I got her,
who said this story? Who said this story? This is an actual doctor claiming.
Yes. Mm-hmm.
Wow.
Yes.
And they're trying to sell this fiction to people that are obviously professionals and experts. Wow.
Right. Yeah. And so this was about, maybe a year into the shots having rolled out. And so I get her and, I had at this point started inserting the shots as a part of a differential diagnosis, meaning when I get you and you have shortness of breath, do you have a blood clot in your lung? Do you have asthma? Do you have pneumonia? I'm thinking of all the things that it could be. I started putting the shot as one of those things in there. And so when I came to her, I continued her workup, but I asked her family, I said, did she have a shot? And yes, she had had 4 messenger RNA shots, which at that time was all you could get. It was, pretty much up to date. And 3 days prior to the onset of all of her symptoms, she had gotten a Pfizer shot. And so I said, hold on, we've got to consider that as a part of her story. And so at that time, I was FLCCC, more well-learned, was aware of Dr. McCullough. I hadn't really used ivermectin yet in my clinical practice at all, but I knew that they were doing it to treat vaccine syndromes and detox pathways. And so I went before the physician that I work with, and I went before the nephrology team, infectious disease team, and the pharmacy. And I said, hey, we have no other options kind of here. Can we Hail Mary it? I'm presenting it in that way, but really thinking to myself that this is going to work. I hope it works. But everybody else was like, we don't know what to do. Literally, they told her family to draw up her will because she had no quality of life. At this time, they had put a peg tube in her to feed her because she could not feed herself. She wasn't getting up out of bed, and she was connected to a dialysis machine that would run every other day. And so I gave her ivermectin, and within about 12 hours, she started kind of coming to. Within 24 hours, 36 hours, she knew her name. She was conversing with her husband again. Within 3 days, she was able to eat by mouth. And she was able to get up and participate with physical therapy. I mean, it was a drastic, radical response. Her kidneys did not fully recover, but she came back to herself about 85-90% just in the 3 days of therapy. And we continued the therapy on for about a month and a half before she had to leave our facility and go elsewhere. But that was the cornerstone case for me where I said something's wrong and we need to get people well. If this is happening to her, it's happening to other people too. And at that time I had started noticing that there was an uptick in cancer coming into my facility. And so I just took a Post-it note and I started writing people's names and I started writing, shots that they had got just to see, if there was any similarities between them. And a lot of the things that I was seeing were neurological issues, was re-diagnosed cancer or new onset of cancer, and then autoimmune issues, just from my own clinical observation. But after that cornerstone case, there were some management changes and my position was just reshuffled around. And the position of retention that I was offered was just not the best fit I found for myself. So I decided to resign. And then that's when I came on to meeting Dr. Meehan. And he had the same vision and mission as I did, stirring kind of in my heart. And so we decided to create something and do something about it because we realized that there was a space that was not being acknowledged and a patient population that was not being properly treated at the root of its cause.
Wow. This is amazing, Richelle. Is there anything we didn't touch upon that we should be talking about?
Thank you. I think, just knowing that there are answers out there, there is hope. There truly, truly is. And it's the simplest of things. And it's not the things that will break your bank. And there are innovative things. There's stuff like stellate ganglion blocks that people are trialing now to help restore taste and smell. We have a provider here in town who's willing to do those as a therapy and intervention. And insurance is covering it too, which is neat to see. But basically, Dr. Meehan and I are licensed in 35 states to provide practice care and prescribe and treat. And so we're really trying to get a hold of people who think they might have been affected either by the infection or the injection long term, because we know there's hope for you. And I think these are things that your primary care could know how to do or that your hospitalist team could be well versed in. It's just that they aren't right now. And part of that's for many different reasons. So we want to acknowledge that and just say that we have a space for you and we want to try and get you well.
Wow. This is amazing, Richelle. Thank you so much for coming on to the Blood Money podcast. And for the viewers out there, make sure you check out AmericaHappens.com. Make sure you go there and subscribe. Give us your email address because with all this censorship, we don't know what's going to happen. And we'd love to have your contact info to keep you in touch with amazing episodes such as this one. Thank you so much, and I will see you on the next episode of Blood Money.